Okay, let's go ahead. I thank Professor Zhang Zhehao so much for his kind invitation for me to present here with the updates with emerging approaches to stroke rehabilitation at the Institute of Elder Health Sciences, National Cheng Kung University. As an occupational therapist, I've been working with individuals with stroke for over 40 years. Now, I'm professor in occupational therapy at National Taiwan University. Also, I'm a member of the U.S. Academy of Occupational Therapy in Bethesda, Maryland, United States. Stroke, as we know, is a major cause of disabilities, and the caregiving burden is enormous, so that the government has provided a number of agenda to prevent, cure, or reduce the disabilities associated with stroke, which is a major problem with the healthcare system here in Taiwan. Today, I would like to present a number of emerging approaches to the management of stroke from the perspective of occupational therapists. Also, I welcome the diverse opinions from other disciplines such as physical medicine and rehabilitation, surgery, nursing, physical therapy, and other professionals. First of all, on the left, during the 1950s, a number of neurodevelopmental approaches have been proposed to explain the development and recovery of motor skills in the upper and lower limb of the individuals with cerebral palsy, developmental delay, or stroke. As an example, Margaret Rule proposed in 1954 for the neurodevelopmental sequence of the proximal to distal gradient of motor development. This idea has been applied to the management of individuals with central nervous system diseases. After that, proprioceptive neuromuscular facilitation, as abbreviated as PNF, has been proposed and popularized during the 1980s. The Brown-Sum approach, as many of you may have heard, has been proposed in the 1970s, and it is still prevailing in many of the clinical practices in Taiwan. Last, neurodevelopmental treatment, NDT, or the Bobath approach, was originally proposed by Bertha Bobath in 1978. Bertha Bobath was a physiotherapist. Her husband was a surgeon, or was a neurologist. The Bobath proposed the Bobath approach, or here, as we call neurodevelopmental treatment, as a major approach to the management of stroke. The above treatment approaches have been seen as traditional because they were proposed for over 50 years ago, and now many of the theoretical propositions and research evidence does not provide sufficient support for the traditional idea, which proposed hierarchical or top-down model of motor control. In terms, as I shown in the bottom, the contemporary approaches have been proposed in the 1980s based on the International Classification of Disabilities and Functioning, or the ICF. The ICF model proposed that personal factor, activity factor, and context factor together interplay to determine the motor development and motor control in individuals at risk or with motor deficits after brain damage. As a famous example, task-oriented approach to stroke rehabilitation emphasized the use of functional tasks for repetitive practice, and the repetition of the movement practice may have promoted brain plasticity change after training, and thus the individual may gain functional progress during the practice. The following constraint-induced therapy, or CIMT, was proposed by Edward Taub in the United States. The first randomized controlled trial was published in 1993 in the Archives of Physical Medicine and Rehabilitation to support the use of restraining or constraining the unaffected limb of the stroke patient so that the patient may use his or her affected arm for functional practice in an intensive manner. Several studies have provided evidence in support of constraint-induced therapy in the United States, in Taiwan, and in many other countries in the world. Recent years, several scholars in mainland China have implemented constraint-induced therapy in their clinical context. There is evidence for the benefits of CIT across different patient populations around the world. Bilateral arm training, or BAT, was proposed by Widow in the United States during the 1990s. The approach proposed that use of bilateral upper limb for functional practice may promote the interplay or connection between both brain hemispheres. The undamaged brain may supply neuron information through the corpus callosum to the damaged brain for feedback about movement area and for the formulation of movement strategy for successful movements. Both the CIT and BAT have been widely used in the clinics and have been incorporated to several clinical guidelines formulated by countries such as the United States and the EU. Some of our published articles have been included in the guidelines as examples of evidence for CIT or BAT. We have also compared the relative efficacy of CIT and BAT. We found that CIT may be used to promote initial recovery in the proximal segments of the upper limb, whereas BAT may be more beneficial for the recovery of functional use of the affected arm. Therefore, both approaches can be complemented to each other to achieve optimal outcomes. Given the advances in rehabilitation technology, several technology-based rehabilitation regimens have been used in recent decades. For example, TDCS, RTEMS, intermittent theta burst stimulation, which are brain stimulation that are non-invasive and could be safe and effective for some patients, have been used in the clinical trials with some promising findings. In addition, the non-invasive brain stimulation, such as the TDCS, RTEMS, or ITMS, has been used as a priming technique before the implementation of other therapy, such as robotic therapy, virtual reality, augmented reality, mirror therapy, or even telerehabilitation. The combination of different treatment techniques have been proved to be beneficial more than monotherapy in specific patients, not all patients, and the literature is growing supporting the use of the combination therapy for specific samples. Now, we are looking for the responders to the technology-based rehabilitation and formulate our treatment protocol based on individual needs and patient characteristics in order for the rehabilitation regimens to be cost-effective in the very busy schedule of clinical practice. Today, I'm going to share with you some of our recent progress in the use of technology-based rehabilitation, with the example of mirror therapy plus exergaming, which will be involved with augmented reality, and a gamified intervention is less costly and friendly to the patients for use in a variety of settings, including the home setting. As a background to our combination of mirror therapy and augmented reality, both practices are gaining popularity in stroke rehabilitation in recent 5 to 10 years. Current clinical guidelines support the use of mirror therapy and gamified interventions in some stroke rehabilitation situations. Mirror therapy is based on the tenet that the use of a mirror, which will be placed in the middle of the table, will provide mirror visual feedback for the patient who moved during the practice to get the visual illusion based on the mirror to promote bilateral brain coupling, which involves the connection of most hemispheres, and thus may improve motor and sensory impairments.
喂，在干嘛？
Augmented reality offers an
睡着了？
interactive opportunity for the patient to
你怎么
practice
才来的？
without the need of wearing goggles.
哦，
The patient
哪有
will
气氛吵你？我
play
怎么快
with
睡
the
着了？不吵
game
你。
in an interactive way, and the feedback from the scores, from the
那你睡觉
sounds,
干嘛？
from the encouragement may motivate the patient to practice repetitively for more and more repetitions and higher scores. The motivating
哪个学校？
nature of augmented reality games serve to be important in
不能因为你漂亮
today's
就一直
stroke
练。
rehabilitation.
哼，
There's literature indicating the benefits of AR for promoting motor, balance, and cognitive recovery. Mirror therapy has been used for over 1 decade as a priming technique to be sequentially combined with other therapy, such as the augmented reality. The hybridized regimen may improve the outcomes better than monotherapy, such as augmented reality alone or traditional rehabilitation, as I will show to you later. There are a number of studies published to provide evidence for the promise of mirror therapy-based hybrid regimens, such as the study by Li et al. Published in Taiwan, the study published in China by Din et al. All the studies provided evidence for the use of mirror therapy as a priming technique in combination with bilateral arm training or robotic therapy or conventional rehabilitation. Or the regimens may improve sensory impairments, motor impairments, functional arm use, and self-rated quality of life. Also, some patients may improve in their grip strength and independence in daily activities. Together, the studies indicated the promise of the use of MT in combination with other relevant treatment approaches such as bilateral arm training, traditional rehabilitation, or even robotic therapy. Given the very limited sample size, there is a need to expand the study based on a larger sample to validate the findings and to identify the responders who be the good candidates for choice when the hybrid regimens are implemented in the clinics. Here I'm showing a number of ways for implementing extra gaming intervention, which is very popular in today's physical medicine and rehabilitation in the United States, Japan, and Europe. Virtual reality involves immersive or non-immersive situations for interaction between the patient and the computerized games. The games may be displayed on a computer screen or on the wall for a wider scope of viewing. The problem is that most of the virtual reality devices require the use of goggles, which may cause dizziness, discomfort in some patients. As an alternative, augmented reality does not require the
正在录制此会议。
virtual reality, augmented reality, and mixed reality. I just want to make sure if I skip this slide. Did you see the slide when I was presenting about the gamified interactions? Yes?
Yes.
Okay, that's fine. Now, let's proceed to the potential benefits of gamified interventions such as Wii gaming, virtual reality, augmented reality, and many other gaming which have been commercial or popularized in today's daily activity or practice for healthcare management. As the games are diversified in their content and their purpose for training, a number of functions can be addressed for the use of gamified interventions. First of all, balance and gait, lower limb balance are important for the patients to move. Safety, that is, functional mobility, comes first. Also, we want to prevent falls. In order to overcome the sense of fear of falls, we will have the patients practice in a safe way with the therapist staying beside the patient and with the handrail placed in front of the patient so that the patient may grasp the handrail when he or she feels insecure. Posture control is a product of practice of the mobility during the gaming activities. Also, the gaming interactions involve the use of upper limb to reach an apple from an apple tree, to pick up a cup from a table on the virtual screen. Also, motor function is an emphasized domain of practice because of the use of the affected upper limb, lower limb, and the balance between both limbs are important for functional mobility. Finally, activities of daily living are important as we have incorporated gaming activities such as moving around in the patient's home setting. On the virtual screen, the patient will practice to learn how to move freely and safely around the situation, overcoming the obstacles and preventing falls so that the patients may have the confidence to practice in their real situations. A number of recent publications have provided evidence for the use of gamified interventions. We have to take note of the gap in research. There is a lack of evidence for immunotherapy primed exergamine in stroke rehabilitation, despite the promise of the hybrid regimens. The combination of immunotherapy, augmented reality, functional task practice, and home-based program may have the potential to augment the rehabilitation. First of all, the amount of therapy or the treatment hours may increase with the combination of hospital-based practice and home-based program. In addition, the use of rehabilitation technology in combination with traditional functional practice may improve the engagement of the patient during the activities. Unfortunately, there is no study that has been published to investigate the effects of immunotherapy combined with AR and other technology relative to AR as a control. To address the gap in research, we proposed to study the effects of AR either with or without the use of MT as a priming technique relative to those matched traditional rehabilitation. We have two hypotheses. First of all, AR practice with or without immunotherapy would be more beneficial than traditional rehabilitation in motor impairments, balance, quality of life, and functional performance. Secondly, we hypothesized that the hybridized regimen, such as MT plus AR, and the monotherapy with the AR would present differential benefits in individuals of stroke because the combination of MT and AR served to be a powerful regimen with two important interventions, whereas the AR involved a gamified intervention without the priming of immunotherapy. But given the literature and our pilot studies, both treatments may render treatment benefits in stroke patients. We need to look at the difference between both groups after therapy. As a flowchart of our randomized controlled trial, we have 140 patients assessed for eligibility. Eventually, 45 patients met the inclusion criteria and consented to sign the informed consent for participation in a clinical trial. The 45 participants were randomized to receive MT plus AR or dose-matched control therapy. The sample size for each group was 16, 15, and 14 respectively, with some dropout during the therapy or the follow-up period. We have 15 patients who completed the MT and AR, with the other 15 completing the AR, and the other 15 completing the traditional rehab. After 3 months follow-up, we have 15 for the first group, 15 for the second group, and 14 for the control group. We did the analysis for the follow-up results with intention to treat analysis involving the technique of last observation carried forward method. Here's the inclusion criteria and exclusion criteria for the randomized controlled trial. The patient have to be at least 3 months after first ever stroke without exceeding 3 years to prevent exceeded standard deviation within and across treatment groups. The patient should be at least 30 years of age with the baseline motor impairment assessment of Fugl-Meyer at the score of 15 to 55 points. The scale ranged from 0 to 66 points. The patient should not have excessive muscle tone abnormality. The modified Ashworth scale score should be below 3 points, with sound mental function to follow the therapist's instructions. The patient has to have the ability to maintain balance by assuming a step-standing position for 30 seconds. He or she should be able to walk with and without assistive devices for 10 meters, so that the gamified interventions involving mobility and loading movements would be safe and feasible. The patient should not have other major neurological disease or participation in other study during a clinical trial. Also, the patient had to sign the informed consent to participate in the study. We excluded patients who had acute inflammation either in the shoulder or other body parts, patients who received Botox within the past month before the enrollment, or those who have serious physical or medical problems such as recurrent stroke, Parkinson's disease, or traumatic brain injury. In the photos, you can see the protocol of mirror therapy that we have used. On the left, as circled in red, we have the mirror therapy implemented with the unilateral approach, involving the use of the unaffected upper limb, whereas the affected arm was placed in the mirror box. There's a mirror in the middle of the patient. The patient was asked to move with his or her unaffected upper limb while looking at the mirror for the image of the reflective movement. The patient was asked to imagine that the image on the mirror should be seen just like his or her affected arm, so that there's a visual illusion that may promote the activation of the neural circuits involved in mirror therapy. In order to prevent the patient's seeing his or her practicing hand, we have a little tray hiding the upper limb during practice so that the patient can focus on the mirror for mirror image without being distracted by the sight of the real arm movement. The practice may be objectless, which means that there's no object involved during the movement practice. The movement can be implemented with some task object, such as a mug. The patient was required to pour in some water into the mug. This is called task-based approach. On the right, the same principles can be applied to practice of mirror therapy based on a bilateral approach. Both unaffected and affected upper limbs were used concurrently during mirror therapy. The patient practiced without or with functional objects. Also, the bed tray was used to prevent sight of the unaffected arm. When a patient was viewing the mirror during bilateral arm movements. The affected arm could not be seen because the affected arm was hidden in the box. Some of the patients may not move simultaneously with both arms doing the same task, such as wiping the table. We allow the patients to try their best to use their affected arm for the best of their practice without the necessity to catch the good arm. For the augmented reality protocol, we have 4 domains of practice: upper limb, posture control, lower limb and balance, and cognitive games. All of the domains are important for recovery from stroke and the integration of the abilities for successful activities of daily living. For the upper limb practice, the patient may use the affected arm for simple movements or more complex movements such as picking up an apple on a tree. The difficulty of the practice will be graded based on individual patients' abilities. As the therapy progresses, the patient will receive more and more challenging tasks. For the posture control practice, the patient would be practicing the games in order to move just like the person in the screen, so that the patient may shift his or her body weight to maintain a balance without falling. For cognitive games, a number of domains of cognitive function were addressed, such as attention, judgment, orientation, calculation, executive functions, such as the use of the playing cards based on the Wisconsin card sorting test. Also, the patients will have the opportunity to practice working memory, which is very important for judgment in their daily life situations. Of course, lower limb movement and balance is important for patients who require repetitive practice of their balance function. The patient may stand with one leg, either with the unaffected leg or the affected leg, depending on the need of the patients. The duration of the movement will change depending on the patient's ability for adjustment and his or her tolerance to the challenge. Endurance is the goal for the training, but for reasons of safety, the patient may terminate during the practice to get a break or asking for a lower level of challenge to prevent frustration or intolerance. For the third group, which we call dose-matched control treatment, involve the use of traditional therapy techniques such as active and passive range of motion of the upper and lower limbs, the use of simple objects such as a wiping cloth for wiping the wet table. The patient may use the assistive device to navigate across the obstacles or without the obstacles. We may place a demand for speed and accuracy for patients who have recovered to a higher level of ambulation so that the task will be challenging and appropriate for the patient to push up. For the bilateral arm training, we have the patients practice activities such as hanging her sweater in the closet or picking up the sweater from the closet for practice of dressing and undressing. In terms of the outcome measures in the clinical trial, two primary outcome measures included focal assessment of the upper extremity, Berg Balance Scale, which is a measurement of static and dynamic balance of the patient. Secondary outcome measures included assessment for sensory impairment, as termed as the revised Nottingham Sensory Assessment, which is reliable and valid in stroke rehabilitation. We have Check-Dog Arm and Hand Activity Inventory, CHEHI, as a measurement of bilateral upper limb activity. Given the importance of use both arms in daily activities, it is important for the patient to learn to use both upper limbs for coordinated movement during daily life. CHEHI is an appropriate measurement for the use of bilateral upper limbs for daily activities. Finally, to address the change in self-perceived quality of life, we implemented Stroke Impact Scale for measurement of patients' reported outcome in their confidence, efficacy in performing physical, emotional, cognitive, and functional activities in their daily life. Stroke Importance Scale is important in the ICF model because participation in daily activities and satisfaction with the patient and the ease of burden of the caregiver is the eventual goal of rehabilitation. Stroke Importance Scale, as reported by the patient or the caregiver, is important to complement clinical measurements administered by the therapist or clinicians. In the study, we use both the objective assessments and subjective self-reported scale to capture a wider spectrum of change from pre to post-treatment and a follow-up assessment. In accord with the IRB regulation, we monitor adverse response during treatment involving the use of visual analog scale for self-reported pain and fatigue rated before and immediately after each session of treatment. To avoid overexertion, we used the Borg rating of perceived exertion. The patient was asked to report their perceived exertion during the activities after the treatment session so that we have a good monitor of the adverse response such as pain, fatigue, and overexertion. Prevention of fall is, of course, important for the implementation of the challenging protocol. Based on characteristics of the participants in the three groups matched without significant differences in age, sex, side of brain, region, type of stroke, chronicity of stroke, severity of stroke as measured by the NIH stroke scale, the patients had sound mental function as measured by Montreal Cognitive Assessment to participate in the study and follow the instructions. The patients need to have some movements with their upper limb in order to practice mirror therapy and augmented reality. In addition, baseline Berg Balance Scale was measured to ensure that the patient can adhere to the requirement to stand with one leg and to walk with or without device for at least 10 meters. Participants in the three groups matched in the clinical and demographic characteristics before initiation of the clinical study. Results of the primary outcome measures indicated that from pre-test to post-test and to 3-month follow-up, there was some change in the treatment groups on the Fugl-Meyer assessment, such as the post-treatment improvement in the MT plus AR group and in the AR group. Whereas at 3-month follow-up, all the treatment groups, MT plus AR, and control treatment improved significantly at 3-month follow-up. In terms of between group differences, we used a two-way mixed ANOVA involving the interaction of group by time to look at which group improved more than the other significantly after treatment or at follow-up. We found that MT plus AR excelled in Fugl-Meyer assessment relative to control treatment, but not to the AR group. For the Berg balance scale, both MT plus AR and AR improved significantly better than traditional rehabilitation. The table indicated the benefits of MT plus AR for successful improvement in operating motor impairments and balance at 3-month follow-up, and the improvement was significantly more than control treatment, supporting the use of the hybrid regimens for improving motor impairment and balance. For the secondary outcome measures, as shown in the table, we have the pre-test, post-test, and follow-up assessment scores for each of the treatment groups. The within-group differences were seen from pre to post-treatment in the MT plus AR, the AR, and the control group for the sensory assessment, either at post-treatment assessment or follow-up assessment. For between-group comparison, our post-hoc comparison indicated that MT plus AR improved more than AR and the control group. AR improved significantly better than the control group as well. Overall, for achievement of treatment success in tactile function, plus MT plus AR and AR are successful. For proprioception, MT plus AR and AR also improved significantly better than control group. But for stereognosis, there are no significant differences among the treatment groups. The findings indicated that MT plus AR or AR may improve sensory impairments in some domains of sensory assessments, such as light touch, temperature, proprioception, but not stereognosis, which indicated the need for including tasks such as picking up coins among a number of objects so that the patient would have the opportunity to practice their stereognosis. For the bilateral arm activity measurement, as measured by the KHI, there was post-treatment improvement for the three groups. At a 3-month follow-up, all treatment groups improved significantly, but between group comparison indicated a large effect size with the marginal significant finding among the groups. The MT plus AR improved more as a trend, but the difference did not reach statistical significance. For functional use of 30 important activities of daily living, MORE was used as a self-reported questionnaire rated by the patient in terms of the amount of use or the quality of use of their affected arm in daily activities. Again, there are post-treatment improvement for all treatment groups across amount of use and quality of movement. The same applied to follow-up assessments, or the treatment groups improved at 3-month follow-up. There was no significant difference among the treatment groups with a small effect size. The findings indicated that the use of traditional rehabilitation, which was matched in treatment dose, would be beneficial relative to MT plus AR or AR in functional arm use in the patient's real-life situation. For the stroke impact scale as a measure of quality of life after stroke, or the patient's improved at post-treatment and at follow-up assessment, there were significant differences among the three groups, indicating the excellence of NT plus AR and AR relative to control, but there was no significant difference between MT plus AR relative to AR. The finding indicated that both NT plus AR and AR are beneficial for improving patient-reported quality of life at the end of the follow-up relative to traditional rehabilitation, but both the hybrid and AR alone groups improved in a similar way without significant differences. As we can see from the table, MT plus AR may excel, exceeding the improvement of AR and CT in RNSA and other domains of assessment, but AR may be beneficial for balance, mobility, for proprioception, tactile, and for quality of life. The findings suggest that MT plus AR or the AR render differential benefits with better improvements than traditional rehabilitation in most of the outcome measures. For the monitor for adverse response of pain, fatigue, and overexertion, we look at the score from pre to post-treatment for the treatment groups. The findings indicated that for the MT plus AR and AR group, fatigue was evident after treatment. The situation applied to the traditional rehabilitation group, that is, all the treatment groups who received 90 minutes of practice per session for 3 sessions per week. It is exerting for the stroke patients, but the increase in the VS fatigue scale score did not exceed the threshold. For comparison among the groups, there were no significant difference among the 3 treatment groups. As a cutoff for monitor of overexertion, we have 15 points in the RPE as a threshold value for monitor. As you can see, none of the groups achieved a score greater than 15 points during the treatment, indicating that the intensive program was not overexerting and can be tolerated by the patients included in the study. To interpret the findings of the study, MT plus AR is more beneficial, especially for improving motor impairments of the affected upper limb and some domains of sensory deficits, especially in the tactile domain. AR excel in improving balance and functional mobility, which are important in daily activities. In contrast, MT and AR are differential in their treatment benefits. In order to improve motor impairments of the affected upper arm and the sensory deficits in the clinics, MT plus AR might be the option. For patients who need balance and mobility training, AR could be useful. A combination of MT and AR or AR could be used to formulate a hybrid regimen as the patient progressed from motor training for the upper and lower limb to balance and functional mobility, such as crossing the obstacles more than 10 meters or walking across the street with the assisted device, which are all important in community-based daily activities. The findings are limited in sample size, and the study participants were recruited from participating clinics in Taipei, New Taipei City, and Taichung, without including participants from the south of Taiwan. Geographical differences should be considered as a possible confounder. In order to validate our findings, a larger sample, including patients from other regions, will be needed. Further research may also study the factors that may predict treatment success after the therapy. Some of the patients succeeded in reaching the clinically significant difference level, but others failed to do so. We need to identify the factors that may predict a particular group of patients who are potentially relevant for receiving the treatment. In terms of the sequence of the treatments, we used the MT as the priming technique, subsequently with the combination of AR. How about the use of AR plus MT as the hybrid regimen? Both sequences could render improvement after therapy, but the benefits could differ depending on the sequence of the treatment. In addition, the type or schedule of combination warrant very careful consideration. We combined MT and AR within one treatment session. That is, in each treatment session, the MT plus AR group received both types of treatments. What if we separate MT and AR by weeks? For example, in the first 3 weeks of treatment, we implemented the MT protocol. In the following 3 weeks, the participants shifted to receive AR, which would be a weekly based combination of MT plus AR. Different treatment schedules, different combinations may render different benefits, or the issues remain unclear. The gap of research needs to be addressed with very careful reproducibility research in the future. Let me give some take-home messages. Our findings support that the clinician may choose the appropriate regimen based on patient's goal. For example, MT plus AR might be relevant for patients who need to recover from sensory motor impairments to implement basic ADL and basic interaction with the environment. For patients who have certain upper limb and lower limb movement skills, balance, and posture control, obstacle crossing are prioritized. For such patients, AR could be the good choice. Both the interventions improve quality of life more than the traditional rehabilitation. That is, the combination of rehabilitation technology could be more beneficial to improve patient satisfaction with their participation in daily activities. The improvement after therapy were retained at 3-month follow-up, indicating that the progress was maintained over the follow-up period for 3 weeks without decrease in the treatment gains. During the 3-month follow-up period, we have the maintenance program for the patients to practice every day during the follow-up period, which may have contributed to the retention of treatment gains after therapy. Further research need to identify the responders and non-responders. We have used multiple
正在录制此会议。
and very limited ability to perform self-care activities. MT plus AR could be a relevant and appropriate regimen for choice. For patients with upper limb and lower limb abilities to maintain balance without falling, and with some ability to perform bilateral arm movement, balance and posture control training based on the interactive games as used by the AR protocol could be important. These patients who require balance and posture control training may not need to receive MT as much as we have used in the study. Both groups improved in quality of life than traditional rehabilitation, indicating that the improvement in sensory motor, balance, and daily activity function may improve patients' perceived satisfaction of their ability to participate in home and community-based activities. This is very important to empower the stroke patients to continue their efforts to achieve better progress in reintegration into the community. Of note, all the treatments improved immediately after therapy. The treatment gains were maintained at 3-month follow-up. As an explanation, during the 3-month follow-up, we implemented a maintenance program for all study participants to practice at home for upper limb, lower limb, balance, ambulation, such that the patients might have maintained their progress after therapy. It is very important to give a very clear protocol for maintenance program, especially when the patients do not visit the clinics as frequently as before. Further research is needed to identify what kind of patients might benefit from either NT plus AR or AR. What kind of patients may not benefit from the interventions? What are the reasons for the success and failure of the treatment? Or the questions remain unanswered. This gap of research needs to be filled in subsequent studies. Let me proceed to one recent research article that is coming soon in the May and June issue 2025 in the American Journal of Occupational Therapy. We implemented the MT preceding augmented reality program in the clinic and home settings for patients with stroke. We used a crossover study design to compare clinic-based versus home-based practice. What is important about the study is that treatment settings are very important to consider because practice context may yield differential effects on motor and functional outcomes. Therefore, the setting of practice needs to be considered and be incorporated into a comprehensive stroke rehabilitation program. We investigated the effects of MT plus AR in the clinic and home setting for comparison. The study design involved a randomized crossover study with 31 stroke survivors consented to participate in the study. The patients received the MT plus AR protocol either at the home setting first or the clinic setting first. I'll show you the study design after this slide. There are 9 treatment sessions in each phase with 3-week washout period between both two phases. The outcome measures, similarly to the previous study, involved Fogel-Meyer assessment, Berg balance scale, K-high, MAR, and stroke impact scale. Because of the importance of these measurements and their relevance to identify treatment effects after rehabilitation, in previous literature and in our prior research, we decided to use these measurements to identify the replicability of our previous findings. As a result, clinic-based practice improved significantly in Fogel-Meyer assessment, Berg balance scale, and mobility as rated by the patient after therapy. In contrast, home-based setting is beneficial for rendering improvement in functional arm use as rated by the self-reported outcome measure of motor activity law. Clinic-based practice revealed maintenance of the gains at our 3-month follow-up assessment in Fogel-Meyer assessment and ADL mobility and hand function domain of the SIS, but the trend was not found for the home-based setting. As a conclusion, home-based practice might improve motor and balance deficits, whereas home-based practice might be beneficial for functional arm use, that is, use of the affected arm in 30 important ADLs. The rating was based on patients' self-reports, which might not be reliable because of the memory bias or subjective judgment by the patients. But in any way, patient-reported outcomes are important to be considered in addition to clinical measurements administered by the therapist. The finding indicated that practice setting is very important for consideration in stroke rehabilitation. What is new about this article? Clinic and home-based practice may complement with each other to optimize the benefits. This means that patients may practice in the clinic setting for improvement of upper limb, motor impairments, and balance. For patients who need to improve their functional arm use in daily activity situations, home-based practice is important because of the ecology, the environment of practice is familiar to the patient, and the patient and caregivers might adopt tools or modalities that are relevant for their daily life at their home setting. both clinic and home-based practice might improve treatment effects. Both might be combined or complement in different proportions, depending on the goal of the patient and the needs of the therapy. This is a flowchart of the crossover trial. Among 130 patients assessed for eligibility, 31 of them were enrolled and randomized to receive either clinic-based practice first or home-based practice first for 9 weeks. Phase 1 of the study lasted for 9 weeks. After 9 weeks practice, there's a washout period for additional 9 weeks. After the washout period, the patients shifted their setting from home to clinic or from clinic to home so that all the participants received both clinic and home-based practice in different sequences. At the completion of the treatment, we did the analysis, and at the 3-month follow-up, we did the follow-up assessment for dropout. To address the dropout issues, we used the intention to treat analysis involving less observation carried forward method to address the follow-up issue, to address the dropout issue. Let me put it in plain language. There's research supporting the benefits of using augmented reality in stroke rehabilitation. The rehabilitation program might include mirror therapy before the use of AR. Our study indicated the use of MT prior to AR might improve motor and balance. So patients involved in either a clinic or home-based setting with a crossover design so that all patients would receive both practice setting interventions. The result indicated that the clinic-based session led to more improvement in motor balance, whereas home-based setting improved more in patients' self-perceived functional arm use in real-life situations. Both outcomes are important in rehabilitation. The findings indicate the need to consider the practice setting. Both clinic and home practice setting might be incorporated to complement each other to optimize the treatment effects. As an outlook into the future, computerized or digital rehabilitation is important and has been used in a number of clinical trials. For example, we have implemented the computerized mirror therapy based on the unilateral or bilateral approach. For the unilateral approach, the patient used the unaffected upper limb for movement. With the camera, the movement would be projected to the right side of the computer screen, which is the good side of the patient's upper limb, so that the patient may observe the mirror image on the computer game to imagine how the hemiplegic hand might move. We used the objectless, which means movement without object, and task-based practice. Task-based practice involved pressing a ball or wiping the table or manipulating daily activities such as picking up a mug. For the bilateral computerized MT protocol, both the unaffected and affected arms moved simultaneously with movement-based practice or object manipulation, which are task-based practice. The use of object-less and task object will enrich the practice context. The environmental factors are enriched with the use of different objects for different activity purposes. The practice under the unilateral approach is based on the tenet of the use of one unilateral upper arm would allow the patient to focus on one single target. The practice under bilateral approach involved the theory that both brain hemispheres might be activated for connection between two hemispheres through the corpus callosum so that the undamaged brain may provide information, feedback about the movement to the damaged brain to allow the damaged brain to control the hemiplegic hand with some feedback information. Clinically, we would practice unilateral and bilateral MT with and without task objects. In addition, traditional mirror therapy, as I proposed above, plus computerized mirror therapy can be used concurrently or sequentially. The combination can be based on daily or weekly schedules. For daily schedules, the patient would practice traditional and computerized MT within one treatment session. For weekly-based schedule, the patient may practice computerized MT for the first 3 weeks, followed by practice on traditional MT in the following 3 weeks, or vice versa. All the efforts were geared toward filling the gap in research, including knowledge, practice, empirical, and population gap. For knowledge gap, our study were designed to address research questions that remain unanswered. For practical knowledge gap, our research addressed the issue that some professional practice, such as the use of mirror therapy, did not have sufficient research findings to support their benefits in specific domains of outcome measures. For empirical gap, our research was designed based on recent contemporary motor control approaches to evaluate the theory or the research question that we proposed. For population gap, we enroll study participants across different centers in different regions, covering different sexes, different age groups, and different socioeconomic classes. I thank the funding bodies in Taiwan to allow our research team, including our graduate student research assistants and the personnel in the hospitals, to allow completion of the study. I thank you for your attendance. May we proceed to the Q&A session?
Thank you, Professor Lin. Thank you, excellent sharing your work. 那我们现在就开放大家提问的时间哈，那现场的可以到前面来用麦克风，那线上的同学同仁，你们可以直接开启麦克风就可以提问。那如果不方便的，也可以打在右边的这个聊天室哈，那我们帮忙帮大家提问。那谁要先提问？好，来，那个我们现场有复健科的医师。
谢谢您带来的精彩的演讲啊！我想请问一下，就是说在 AI 的那个疗程里面有一个是考文力，有加上考文力一天，然后因为看起来那个后面的一些那个分析的outcome，主要是以那个就是动作的那个就是进步 以控制为主那想请问老师，就是那个在疗程里面加上training是不是会对这类的病人更有帮助？就是我想要请教一下，谢谢。
有没有林老师有听到吗？
May I ask the help of the moderator? I cannot hear that clearly.
Oh, sorry.
May I have the question again?
这样子有听到吗？
听得到。
好，那我再请那个连医师再重讲一次。
老师，我想要问的是，就是刚才前面在那个 AR 的那个就是有在加
I'm sorry, I cannot hear that.
不知道他听不清楚，可能
我要近一点，是不是？喂，老师好，老师，请问这样有听到我的声音吗？
听得到，严医师您好。
谢谢老师。老师，那个我想请问是说，就是刚才前面在那个AR 的部分那我看那个在那个治疗的项目里面有加上 cognitive training， 就是在那个训练的过程中。那我好奇的是，因为最后的那个成果主要的分析就是个案他在那个动作控制上面都有那个很好的进步。那中间加上 cognitive training 的那个部分呢，这个部分是不是加上这个部分会对这类的病人特别有帮助，还是怎么样？这个部分好奇想请问老师，谢谢。
OK， 我中文、英文都可以Would you like me to answer in English or Mandarin?
中文可以了，大家。
For those who may not familiar with Mandarin, I can respond in English. Let me explain why we have different domains of practice in the AR protocol, given the importance of cognitive ability. For example, the patient should be able to follow the instructions of the therapist to ensure that the patient has the ability to understand the instructions and follow the instructions. We have a screening for mental function. The patient should have the mental function to follow the instruction and to remember the steps to implement. In order for the patient to practice in upper limb, lower limb balance, posture control, the patient also need to practice cognitive games so that they have the judgment to make decisions about their daily activities. For example, the patient need to remember what to do when he or she go to the grocery. The patient need to remember what to talk over the telephone. The patient need to remember what time he or she should reach the destination for an appointment. 病人需要记得很多日常活动的事项，例如到超商要买什么，例如过马路要赶在什么时候到达目的地，例如在对话、讲话或通电话的时候能够记得要讲什么。Because of the problems with language, communication, emotion, memory, and judgment in most of the stroke patients, there are items addressing cognition in the stroke impact scale. 在 stroke impact scale 里面，除了 physical function 以外，还有认知、情绪的项目。认知的项目包含专注力、记忆、沟通、情绪。There are a number of items addressing cognitive functions, such as memory, attention, communication, and judgment in the stroke impact scale. To achieve a higher score on the SIS scale, the patient need to have improved cognitive deficit. In order to achieve improvement on the SIS, That is, the SIS included items of physical, cognitive, and emotional items. That's why cognitive activities are important to be incorporated in the AR protocol so that the patient might recover from deficits in cognitive-related functions such as memory, thinking, attention, and communication.
好，谢谢老师的答复，这个非常清楚。那 any audience 现场有没有同学提问？那我可以先问林老师一个问题。
好的，曾教授。
是，好，我觉得这些 approach 都是非常的新颖那感觉也是一个新的一个曙光。那我要问的是说，要把它应用到现在的临床日常的这个应用的话，这个不管是在健保端或者是我们治疗师这边的准备，大概要怎么样子来进行？
Okay. The question raised by Professor Zhang is very important. He asked me about the feasibility of the treatment protocol, which involved mirror therapy, augmented reality, implemented either in the clinics or in the home setting. Let me put it this way. Both MT and gamified interventions have been popular in most of the clinics in medical centers, teaching hospitals, and some private clinics across Taiwan. The issue is that mirror therapy is simple, but very few therapists have used the mirror therapy to its full benefits. AR is not very costly. It is much less expensive than VR and has been available in many hospitals and private clinics. The problem is that the combination of MT plus AR might improve sensory motor better than AR or traditional rehabilitation. Because of the difficulty in improving sensory motor deficits in stroke patients, mirror therapy as a priming technique seems to be useful for warming up motor relearning process, and the addition of MT plus AR or MT plus other rehabilitation implements might improve the outcomes. The schedule in the clinic is very busy. For example, we have 40 to 50 minutes for each session. In the hospital, we might implement MT for just 20 minutes, followed by AR for 20 minutes, with the rest of the 5 to 10 minutes for functional training or home program instruction. In this way, the schedule can be rearranged to incorporate technology into functional training to improve the outcome. In terms of the issue of implementing the practice in the home setting, we have used the tele-rehabilitation. That is, the use of the video conferencing, in which the therapist might monitor the patient's practice at home so that the feedback can be provided immediately, and the videotape can be used for discussion when the patient comes back to the clinics for OT or PT. The patient's practice at home setting will reduce the burden of therapists in the clinics, and the practice at the home setting is beneficial for functional activity recovery. 我刚刚提到的就是在临床上，如果在教学医院一次治疗只有50分钟，那么我们善用时间， 例如20分钟的 MT、20分钟 AR 来接续功能训练或者是居家方案的指导。那么我们可以结合复健科技和现有的复健治疗，并且利用居家练习来填补医院实践的不足，并且让病人善加利用居家环境熟悉的环境事物来做功能练习，填补在医院练习不足之处。这样子的组合可能可以整体提升复健治疗的效益，并且节省治疗师在医院里面1对1人工治疗花费的时间，并且这样子的方案列为居家练习，仍旧是属于在医院里头 OT、PT 能够申请健保给付的一个项目。居家练习是一个搭配医院治疗的一个配套，不会取代医院的治疗。AI 或 AR 这些科技也不会取代治疗师、医师的一个判断。所以复健科技融入现有的复健治疗来增强效果，节省人力，并且提供病人更多居家练习结构化的一个方案，可能可以提升总体的复健效益。
好，谢谢。那我再追问一下，林教授有机会开设进一步的这种类似工作坊，让大家可以有机会再学习这些应用的技巧吗？
是的，我想实务操作或者有一些 videos 让大家可以看得到实际的病人操作非常的重要。那么由于这个档案受限，我没有能够把很多的 videos 或照片通通放进来。那么后续如果有机会，我想这个值得来介绍推广，而且成大的电资工程技术可以研发很多适用的 AR 或者游戏软体，来供教育水平或者是社经状况没有办法完全符合理想标准的病人，在一个比较简易的科技、简易的电脑使用上，能够普及这些游戏治疗的一个方案。那我想后续的交流非常的重要。那我也期盼能够跟成功大学有更多更深入的一个交流，来推动这些复健的科技化。
谢谢林教授这个愿力哈。那现场的同学，我找 Q 我的，
喂，
有
老
我的同
师有听到我
学大家
的声音吗？
OK，学生因为他也在做中风的研究，
老师
请问
有听到我的声音吗？
有？
可以，请说。
可以，好，老师我是张开哦。
是。
对，我想问一下老师，那个镜像疗法实务上在操作的一些问题哦，就是我自己对镜像疗法的概念，就是他必须让病人就是投入去相信说那个镜子里面的手真的是他的患侧手，对啊，但是就是我们应该说我不知道该怎么去引导病人说他真的可以投入这个情境，就很多病人会看着镜子，然后我也不知道他的脑袋在想什么，或者我也不知道他有没有投入这件事情。然后甚至有些病人就做一做会觉得很无聊，然后也不知道自己在干嘛这样子。所以孙导在实务操作上，我们有什么办法可以引导病人比较投入这个情境里面？谢谢。
好，如果我们回到一个很切合实际的状况，假定我有20分钟，让镜像治疗是一个暖身、开机、启动的一个辅助方案，它不是所有的 OT 活动，而是 OT 一堂课40到50分钟里面的一个暖身起跑。假定我只有20分钟来执行镜像的暖身，一开始我有 mental function 的基本要求，例如 MMSE 或 MoCA 达到22分以上，可以理解3个指令，包括注意力、记忆力、工作记忆，可以符合这个基本要求，它才能够在这20分钟里得到镜像治疗的好处，所以是有筛选标准。第二，为了让病人能够专注， 最大的干扰是病人的偏瘫侧跟健侧非常不容易同步协调执行相似的动作。为了减少这个问题，近几年兴起的一套途径叫单肢途径，病人只使用健侧边来执行动作，这个动作可以是徒手动作，或者有物件操作，例如倒水，或者用抹布擦桌子，或者抓握杯子。透过单肢，也就是健侧手单边的活动，病人观测镜子上面的导引，这个导引投射出病人执行的动作。那么为了引导病人专注在镜子的中心，我们会在镜面上面贴一些 sticker， 这个 sticker 可能是数字，可能是颜色。那我们每隔5分钟会抽换这个贴纸，问病人现在镜子上面的贴纸是什么，来确保他听得懂指令，并且能够看到镜子。接着再问病人他在镜子上面看到什么。如果他的描述跟实际的动作差距太远，那么我们可能要降低困难度，缩短练习的时间，特别对于专注力不够久的病人，必须降低难度，以健侧手执行简单动作，而不是双侧手执行复杂的击物动作。从简单到困难，会依据病人的能力还有专注程度来做分级，循序渐进。我们创新的地方在于，这个矮凳遮蔽了健侧手，病人看不到健侧手，比较有机会专心看镜子。过去的镜像治疗没有遮蔽健侧手，病人常常分心在观看自己的手，特别是在执行功能性活动的时候，专注于倒水而不能观看镜像。为了这个问题，我们使用这个矮凳遮蔽掉病人的健侧手，病人看不到健侧手，要看只能看到镜子上的投影。那么透过大约10分钟的暖身，让病人熟悉了，可能我们会用简单的物件，例如拿起杯子或者握住杯子，看看病人 hemiplegia 的程度，来选择 Just Right Challenge 的活动。到最后，理想上是进入双肢的击物动作，两边一起使用抹布擦潮湿的桌面。这个时候，病人仍旧只能看到镜子，他看不到好手，也看不到箱子里面的坏手。所以主 block 掉自己的好手，让病人只能够看到镜子，是镜像治疗成功的第一步。我想临床上的 OT 忽略了这个重要性。
了解，谢谢老师。
非常谢谢林教授的这个实践，而且这个非常精辟的这个经验啊。那因为我们的时间已经这个有点超过了，所以有些技术性的问题。不过我们大家还是来感谢这个林教授给我们的这个指导啊，好，希望下次还有机会再请他来这个分享。谢谢大家，谢谢林教授。
If any of you have any questions about my presentation, you are welcome to write to me at my email address, which can be found on the website of NTU. I will be happy to address any of your concerns. I thank you so much for your participation.
谢谢。
如果可以麻烦大家开一下，谢谢。
我们拍个大合照。
好，3、2、1，好，谢谢。
好，谢谢学长，谢谢。
OK， 谢谢张老师，谢谢大家。如果有问题，欢迎写到我 email 好。